What we're going to do is there are microphones on the sides. I ask folks to line up behind the microphones. If you have questions, please make them questions, brief questions, not long-winded comments, and address the panel, and we'll do our best to answer them.
Hello, so yes, my name is Khadija Tua, and I'm a behavior resource nurse here at Baystate. And we see a lot of the opiate epidemic here. And one of the big cries that our staff hear is they don't know where to send people who come into our doors who are very vulnerable for help. So I'm wondering if you could tell us, especially since you, sir, Dr., are on the governor's panel with the new opiate epidemic, how are we bridging the gap? Because right now we have physicians that don't want to prescribe, and we have laws that prevent nurse practitioners from being able to prescribe and want to help this epidemic. So where is the push going with the legislature so that we can actually offer services to people who come to our doors?
So that's a great question, and I want to acknowledge a lot of work has been done over the last several years that have tried to attend to addressing the treatment gap, and you mentioned specifically legislation around allowing other types of prescribers to prescribe buprenorphine other than physicians, and that rule change was actually made so that physician assistants and nurse practitioners can become waivered to prescribe buprenorphine. So that is a huge success that I think has happened in the last year. In addition to that, there was an increase in the cap for physicians to be able to treat up to 275 patients as well. And so those are some of the things that have been done in the last couple of years that specifically attending to expanding the capacity for medication treatment with buprenorphine. There's a number of other initiatives from funding sources to try to assist programs in expanding their capacity to use other sorts of medication as well, from using extended release injectable naltrexone in correctional facilities as well as in clinical stabilization services and bridging them to care, and a number of innovative ways that medical centers represented by all of us here that are working to try to move towards initiating treatment on demand, if you will, or at the moment when people need it. So without going into too much more, I want to acknowledge some of that work that's been done.
Talk a little bit about your consult service, maybe?
Just one.
And about Colleen's work.
Okay, so so I'll just talk about two kind of innovations and that are not filling the gap completely, but I think go a long way to addressing the treatment gap. So the first in the inpatient setting is addiction consult services. So addiction medicine itself is now being recognized as a specialty in medicine, like cardiology or nephrology or infectious disease. And so along with that, a lot of us think that we should, especially because so much of inpatient hospitalization is actually driven by the complications of substance use, whether it's the preponderance of trauma that really has can be traced back to generally a lot of alcohol use, or when you said that Baystate is being affected by the opioid crisis, I think you're probably talking about infections as well as overdoses. These are particularly sick patients in the hospital who are struggling with substance use, and this is an opportunity to help them be safer, get them information they need around harm reduction, and then if they're interested, to start treatment. So we have that at Boston Medical Center. Mass General has a service as well. We've gotten a lot of interest, including from this area of the state, in trying to figure out how to spread that model so that we can use inpatient hospitalization as a way to initiate treatment. So the other I think innovation that really does come from Massachusetts is called the Massachusetts model, which is nurse care manager focused office-based addiction treatment. So you talked about prescribers as really being the issue, but the Massachusetts model for office-based addiction treatment actually relies on RNs, not the prescriber, but really having an RN work as a nurse care manager who works at the top of his or her license and really manages these patients like they have a chronic condition. And so 40 plus of the 50 federally qualified community health centers in Massachusetts now have an RN, nurse care manager, who's backed up by a physician to be able to provide buprenorphine and naltrexone treatment. And no other state has that level of coverage and accessibility to addiction treatment through its community health centers. So again, I don't want to pretend. I can tell you in our community today, I was struggling to get people the treatment they needed for methadone slots and also for buprenorphine. So it's not enough, but it is a huge victory, and it's really been a public-private partnership. It's facilities that have stepped up, but also some support from the state as well.
And that latter program is what supports the buprenorphine treatment programs that are in our community health centers, particularly Mason Square, where I have my practice, and also Brightwood.
Hello, my name is Steve Jones, and I think you made a very compelling case, and you've tried to answer it now, that the capacity for treatment is the major problem. And I don't know if there's any magic we can do to make it more available, and I wondered, do you think it's possible that all these restrictions on methadone could be eased? And I guess I would say one other thing, and that is that people shouldn't talk about detox as treatment.
Go ahead.
So thanks, Steve, for bringing that up. I think that restrictions on methadone, we do need to be more creative. So 3 drugs is not enough, but the way we deliver each of these medications is very idiosyncratic. Methadone has it has safety concerns that are real. And so does that mean that we have to have what's really a super structured, punitive, alienated system that's like marginalized from the rest of healthcare, which is really how methadone is now? I don't think so. The evidence that Rob presented is super strong when it comes to medication, but just like with the medication for HIV, that's not enough. That's not enough. So to address the HIV epidemic, we didn't just create the medications, we created whole systems of care, which essentially was rolling out the red carpet to get people into care. And that required a lot of addressing and blowing past stigma, and a lot of financial investment and inclusion of multiple disciplines. It's not just about a doctor writing a prescription, it's about really creating a whole system of care. And so I think we need to do the same thing around medication for opioid use disorder. My other hesitancy of what your comment was is just to recognize that not everybody is going to be ready for treatment. In fact, most people are not going to be ready for treatment at any given moment. Over their lifetime, they will. And so when they're not ready, we can't give up on them. We have to come up with other things. And I mean, Insite is a fantastic example of Darwin, the way he talked about creating this pathway to treatment for people who aren't ready yet, I think is really something that inspires me anyway.
I tell you what, I wouldn't, so I mentioned I have my practice at Mason Square and buprenorphine, and I have patients who I know are going to go out and use, and there's really, I mean, I can offer them a naloxone kit, but there's really nothing I can do medically to help them in a safe, inject in a safe way. What I wouldn't do to have a place like Insite where I could walk them over or refer them and say, okay, I get it, you know, this is where you're at, and you know, let's be sure that you're safe, because you know, it's a cliche, but once someone is dead, there's no possibility of recovery.
Hi, my name is Jennifer Kimball. I'm from Berkshire County. I have a question for the gentleman who presented about Insite. I still found the amount of overdoses a little bit concerning, and I had some questions around what's the probability of giving people who wanted to inject heroin or other opioids a standardized product, a medical grade product that we knew what the strength was?
Yeah, that's a great question. So those overdose counts are a function of fentanyl, which entered into the Vancouver drug market in 2015, 2016. So those are shockingly high. And Vancouver is overwhelmed with overdose fatalities. One supervised injection facility is simply not enough at this point. So others have been opened and are opening across the province and Canada as well. In terms of, so you get to this issue, this is why we see these deaths, because fentanyl contaminates the illicit drug supply. In Vancouver, there are prescription heroin programs. There was a trial when I was there 2008, 2009, 2010, which was published in the New England Journal of Medicine and did show that people who are prescribed diacetyl morphine, which is the medical term for heroin, can do better than other medications that are available for a specific group of people. So that is being tested more fully in Vancouver now and across Canada. It's heavily restricted federally, of course, but I think it warrants evaluation, certainly.
I was, the last couple of days, I was down at Boston Medical Center talking to some of the addiction medicine fellows who are there for a research conference, and one of them presented some data from Vancouver on some of the diacetyl morphine work that they're doing. Actually, they've switched over now to using hydromorphone. They've shown that dilaudid hydromorphone works as well, and there are many fewer restrictions in terms of getting it. So, yeah, we did not address that issue in this panel because, to be honest with you, I was not sure we as a community are ready to talk about that. But clearly, if the adulteration of the street opioid supply is the problem, the answer might be to provide, whether it's hydromorphone or diacetyl morphine, USP. Basically, we know exactly what people are getting. But I don't think we're quite there yet. I think we are ready, though, to talk about SIFs, particularly since there is a bill in the State House. My understanding is it hasn't yet gotten out of committee. Do you want to talk a little bit about that?
Now that I can talk totally fine.
Welcome back. We're glad
Sorry.
you're well.
That's why I faltered when you were like, come up to the podium. I'm like, I can't, I'm dying right now.
Please don't.
So we have a bill called S-1081 that was written by, Senator Brownsberger introduced it. It was actually written by service providers and drug users. We were very adamant about including the voice of the drug user and who would be using the consumption room. The problem we're having with the bill right now is nobody has stepped up in the state of Massachusetts to say that they are willing to have a safe consumption space. Obviously, we would want it in an area that is high drug use density, being Holyoke, Springfield. However, the fact that Springfield is just willing after 20 plus years, like I worked on the first campaigns when NIMBYism ran us out of Springfield, because apparently there were no heroin users in Springfield, just so we all know, we're very clear. But, logistically, do I want, obviously, yes, I wish that I could say this bill is going to get approved, by the end of the year. The realism of that happening is not too positive. However, when I was following syringe exchange as a wee little harm reductionist at 15 happening here in Massachusetts, I never thought that we would get a syringe exchange open by 95, 96. I really hope that we have them. I don't think Massachusetts is going to be the first state unless you all get up and fight. But our bill is in the 4th step. There are 13 steps. The good thing I can say is that we were at the part of the bill where they can put us off somewhere to die or kind of allow us to move forward, and we are moving forward to the 5th step. So.
But my understanding is there is sort of a catch-22, right? A community needs to step up.
The community needs to step
up to say they're willing to do it before politicians at the State House are going to sort of stick
Right.
their neck out to sort of push this forward, right?
Right.
And just to add why a state bill is so important, other cities in the US are implementing them, Seattle, I think, being farthest ahead. It does worry me. The federal, drug possession is a federal law, and so I would be concerned for the liability of the staff that work at a facility in a city that's authorized. One, if there could be federal involvement. And so a way to prevent that, or a way to sort of mitigate that, or create a buffer, would be to have state authorization or state legislation, which would set up a state and federal legal battle, essentially, which would help provide protection legally to people that work in a facility. So I'm very encouraged by what's happening in Massachusetts. The fact that it's at a state level is very important, I think. But I hope other cities will continue and will have the courage, I'm sure, to open them and make them happen, and we'll see with this federal administration how they act.
Who's next? I think over here.
Hi, my name's Doan Fenimore. I'm a nurse. I've been doing this for, I don't know, maybe 10 years or so. And actually, you just answered my question. My question was, at an injection site, supervised injection site, a patient does leave the facility after using and gets into an automobile accident. And so you just pretty much summed that up for me. Because I'm used to being in medication-assisted treatment, where we are actually, prescribing the methadone and giving it, therefore, we can be held liable if the assessment isn't correct. So I guess you just answered my question.
Yeah, those protections are provided at Insite. Things that nurses can't do at Insite, they can't handle the drug themselves, and they can't actually inject someone. They can provide education, safer injecting education, can provide swabs or alcohol to clean an injection site, but they can't actually inject someone themselves or handle illicit product.
My name is Jessica Sweeney. I'm a lifelong resident of Holyoke, Massachusetts, and I'm currently a physician assistant student at Baystate University. We're doing rotations, obviously, and I've encountered multiple times in the ER or in inpatient patients who don't necessarily want to be labeled drug user or be put on that wavelength. My question and kind of concern is, what do you do as a provider if you're working inpatient and possibly outpatient? I've seen it inpatient where you have a patient who either is knowingly know is an opiate user or abuser, or someone you don't know, and they're getting visitors, they might be using in the hospital and you're not aware of it. And I thought that sounded crazy because we're treating patients. We want to treat them. We don't want patients to go into withdrawal, but there is that level and that fear of telling someone the truth. And so I have encountered it in rotations. Kind of what's in place in the inpatient world for when you encounter something like this, because I don't want to give a patient a medication that I've prescribed them without realizing that they've already taken another drug and possibly lead to cardiac arrest.
We got it. Alex, that's yours, man.
So I think the question's about substance use in the inpatient setting, and what do we do about it? And the first thing we do about it is we talk openly with the patient about the fact that you're worried about them going into withdrawal and you want to try to treat their withdrawal to keep them comfortable so they can stay in the hospital. And so you're saying that sometimes patients don't want to disclose because of the stigma, and that's really a problem with the stigma. And so I think we have to do as best as we can to try to send a message that gets through or around or relieves that stigma. A lot of inpatient facilities don't treat withdrawal aggressively, and if they treat it at all, it comes with that sort of stigma. And so people don't want to go to those facilities. They don't want to stay in those facilities, and they're not gonna get good quality care no matter what. So at Boston Medical Center, we treat withdrawal aggressively. That's the good part. The hard part that you bring up is that if somebody uses in the hospital, that is like, that we don't have a great way to deal with it. And we need to figure out a good way to deal with it. And actually, I think the healthcare in general, it can feel marginalized. When you go through the emergency department in any sort of busy emergency department, there's a lot of loss of dignity for anybody, regardless of whether you have a substance use disorder or not. You know, they're not private spaces. It's not a fun place to go. And so this is just exacerbated. And then if you make the staff nervous by, using on site, they resent it. And so this isn't the way it should be. But I can tell you that happens also at Boston Medical Center. So we're not perfect, and we still need to figure out how to do it. And I'm amazed that you're even thinking about it at this stage in your training, because this is a problem that needs to be addressed. Now, there are models but even I know from my experience, even in Vancouver, where they have at St. Paul's, they struggle with this issue as well. And so one answer is to have supervised injection in a hospital. That's like, we're probably going to have it in the community first before we have it in the hospital. But so anyway, I don't have a great answer other than that, to say that I'm glad you're thinking about it.
And I want to add one other point to that, which is also some great work that's been done in Boston as well, is highlighting the importance of the language in which we use. And as a sort of a learning opportunity, I also wanted to commend you for being open to thinking about this. But there is a growing body of literature that suggests that the language that we use is very important and can have impacts on outcomes for the treatment of persons that use drugs or have substance use disorders. And so not referring to individuals as drug users or in a particular pejorative way or addicts and really makes a difference. And so in training and working with other medical professionals, there's still an opportunity there to really communicate better in a more dignified, non-judgmental way.
Great. Thank you, guys.
Hey, I'm Kati Simon, and I'm one of those drug users those innocent youth turn into, actually. I'm here with SIFMA Now and NEUU. I have two quick questions. I hope you don't moderate me out here. Firstly, I'm a bit concerned to hear Vivitrol equated with agonist treatments in a sort of neutral way on this panel. I don't know if you've seen the NPR and ProPublica investigative reporting on how it's being marketed aggressively to the carceral system, which is so biased against agonist evidence-based treatments. And also, I've read some studies which show that some studies with Vivitrol outcomes have been so bad that they had to discontinue the study because the Vivitrol group was just being so underserved. So I was wondering about a comment on that. And secondly, I'm wondering, all of you here are from a medical background, and I think medicalization as a model definitely has, its great points, but there are also major weaknesses. For example, drug users as a whole, in these amazing presentations have been seen mostly as a passive patient population, when harm reduction was actually started by drug users ourselves. So I'm so happy to see harm reduction being mainstreamed and having audiences like this being introduced to it. But I'm wondering, how do we include drug users themselves, nothing about us, without us, more in a medicalized model? Okay, 3 questions, I was lying. And finally, I'm just wondering, Governor Baker came out with an omnibus bill to present the Massachusetts legislature, and I'm wondering what happens when medicalization just becomes equated or is indistinguishable from, a carceral model. Because in that bill, once again, the idea of 72-hour involuntary holds comes up, which can be extended indefinitely by any medical professional. Now, whether or not you care about the autonomy of drug users like me, this is going to cause a huge amount of overdoses when people come out angry, violated, traumatized by these sorts of holds, and come out and use with lowered tolerance. So that's it.
I'm ready to take on your 3 questions. So the Vivitrol question. So I was involved with a lot of the as Rob mentioned in his talk, I was involved with a lot of the Vivitrol studies, and there are a lot of concerns about Vivitrol. It is a tool. There are some people for whom it's appropriate, but I agree with you that there are a lot of people for whom it is inappropriate. and not the optimal treatment. I think ultimately we want to get to a point where when we're talking to folks about treatment options, we are doing individualized treatment. These are the options we have. We have methadone, we have injectable naltrexone, you'd have to detox, which you've tried to avoid most of your adult life. And if you come off, but the thing is, if you come off it, then there's no withdrawal when you come out. There's buprenorphine. There's going to be injectable buprenorphine. There are implants. There are going to be all kinds of options, and that really, when a person comes into treatment, and then there's detox and other things, that there will be a discussion, a shared, like we do for all other disorders, conditions, a discussion about all of the treatment options, their pluses and minuses, and patients get to choose. The problem in the criminal justice system is that that kind of a model has not taken hold in criminal justice. There's traditionally been a lot of concern about agonist treatment, and yes, some of the marketing, I think, has taken advantage of some of the stigma of the agonist treatments in those settings. There have been a lot of people in the addiction medicine community who are equally concerned about this, and equally concerned about judges or criminal justice people making what are essentially medical decisions about what treatment a person should be on. So, so there is a lot in that first. That was the first question. The second question, remind me what the second question was.
It's about including drug users
Oh, yeah.
in the medicalized model.
So I believe that it is absolutely essential when you are trying to create programs, and I don't care if it's for drug use or diabetes or hypertension, when you are designing a medical program to meet the needs of the population you're serving, you need the voice of that population. And that's really what the whole community health center movement was started based on that, right? That it really is the voice of the community that's affected, that should be engaged. So I agree with you, and we need to do a much better job of that. I think Rob would agree with that. And the third question was?
72-hour hold.
Oh, the 72-hour hold. Most of the ER docs and other people I know are opposed to that. I think that's not a great idea. There are rare circumstances where, we do that for people who are suicidal and clearly have no ability at a certain point to make a decision for themselves. But this is really a different circumstance. Clearly, if we had better options, like sending people to SIF or sending them to treatment, those would be preferable. And I think part of the reason for this panel, from my perspective as the organizer, is because I'm hearing all these policy prescriptions like this being proposed when there's no evidence, right, that a 72-hour hold is going to do anything, whereas these things we've heard about tonight, for which there is evidence, let's just say the policy, we've made strides. We've heard it. We've clearly made strides, but only 6% of folks after an overdose in Massachusetts are getting on effective medication. That's something that we clearly can do something about. Anyone else want to take?
I would say in terms of the operation of Insite itself, it's funded by Vancouver Coastal Health, which is the universal health authority in Vancouver, but that's the funder, and then it's run by Portland Hotel Society, which has a long history of running harm reduction programs in the downtown east side, and a lot of staff at Insite are folks who use or have used themselves, and as I mentioned, there are peer counselors in what's called the chill out room, which is where you go after you inject. So that your comment is incredibly poignant and critical when designing and operating SIF to make them successful. It really needs to be from stage one and moving forward to have that involvement. Yeah.
I'm just going to add, I think there's been a little bit more of a a definite push in Massachusetts to have peer-based programs. And as I was trying to say, like with doing outreach, we're seeing a lot more people who are drug users advocating for themselves and wanting to be part of the voice at the table, the agency that is helping them, whether it be housing, whether it be health, education, or like Peter was just saying about like report backs from overdose. And this is what's frustrating doing a peer-based outreach program. Even though I can use an Excel spreadsheet, I can't prove how many people who actually overdosed I'm helping get onto methadone or Suboxone when they've actually hit that point of an overdose, maybe their 5th, their 10th, their 1st, where they want to seek treatment. I guess that's a little sliding away from client advisory, but there is a definite empowerment that's happening among drug users, and I think we need to see more of it medically based. Yeah.
Absolutely. I mean, a lot of the changes in the medical system around HIV medications, for example, happened because of activism from ACT UP and other groups that reflected the population affected, who said, we want these medications, we want them now, people are dying. So I absolutely agree with Jess that, advocacy and activism really plays an important part in moving the needle forward. No pun intended.
Hi, my name is Wendy Penner. I work in North Adams. I'm a substance abuse prevention professional, and I also do a lot of work on the opioid epidemic. And I just want to thank you. This has been incredible to learn about the great work that's happening and hopefully ways we can do more in Berkshire County where we're extremely under-resourced. But I want to say that as a prevention professional, the opioid epidemic has everyone's attention. Prevention really doesn't, and I was really disappointed to hear the response to someone who brought up prevention, because what we know is that when people start to use substances when they're young and their brains are still developing, they're really at such an increased risk. And where I'm working in North Berkshire, the use of alcohol and marijuana in the home with children is rampant. And I would just my question for you is, can you please, when you speak about opioid addiction, always remind people that early use of substances is a critical part of solving this, and that prevention, dollar for dollar, is an important part of solving the epidemic as well.
Absolutely. And I don't think anyone on this panel disagrees with that. I mean, prevention, there is a whole science to prevention. And maybe next year's forum, we need to have a forum on prevention, what can be done in the community in terms of prevention. My only thing was that it was a little off topic from what we were discussing. I understand, I think we all agree that it's really important. But again, what we were trying to address is there's a whole generation of people now who are dying. And there are things we could be doing to save their lives that we are not
Absolutely.
Doing. And you're right, it's important so we didn't talk about the efforts that are going on to do safe prescription and reduce opioids in the community and to do community prevention efforts and school-based prevention efforts. You're right, I mean, that's a whole topic unto itself. What we were really focused on this evening, and I hope that came across, is the concern that, as Dr. Marshall mentioned, we are at a rate of overdose deaths that created the impetus for many places around the world to take some more innovative actions. And I think part of this was to hope that maybe we could get the political will, and the community support to start to think
Absolutely.
about some of those
and
things.
I applaud you for that. Thank you.
I just want to also say that I think I grew up in Western Mass, and I was the drug-free class of 2000 through the DARE program, and I think we had one of the highest smoking rates when I graduated. Yeah, I know. Well, it's coming back again, right? But I just want to say though that I think and what I felt like was one of the underlining things is the realization and the acknowledgement that drug use does exist and it is part of our culture, whether we like it or not. And when my experience as a youth is when I started using drugs or anybody else did, the prevention education stopped. And I think that the focus historically has been stopping the onset of use, which is incredibly important, of course, but what happens when that person starts using drugs? And what happens when that person, are using drugs because they feel good and they're not as bad as everybody has told them to. And so I think that needs to be put into the conversation as well, and that's not talked about. Yeah.
I want to bring up one other piece to this, which I do maybe is a little bit of a bridge here, is that, and you mentioned that brains change our whole lives actually, but there is a particularly vulnerable time, and there's a lot we don't understand about prevention. There's also a lot we need to do to adapt treatment to people who are younger. And there's the way, like for example, a methadone clinic is not, it's not a great place for a number of people, but for an 18-year-old, it's not, we're not designing the methadone clinic to serve that person's needs. And I would argue that, an 18-year-old who's overdosed, we should really be thinking about, methadone as one of, it's one of the options, right? But we don't have a treatment facility that really tailors to their needs. So, as we think of creative solutions, I think the youth is an important area where we need to develop new innovations, essentially, that's going to work for them, that they're going to be willing to come to.
But to go back to the point about prevention, so you're right, we didn't spend any time really on primary prevention, but there was a lot of discussion of secondary and tertiary prevention, right? And clearly syringe access is a major part of that. Naloxone distribution is a big part of that. Interventions around safer use, supervised use is a big part of that. So, if you want to speak in the language of prevention, we can say, even though, Rob spoke about treatment, but, there really was a lot of prevention content here, but not primary prevention. And,
Yes, true.
and that will be maybe next year. I'm going to talk to you. Maybe we'll make this an annual thing.
Thank you.
I just want to clarify what I said. It's more about we need to destigmatize for kids and be honest about drug use. If somebody had really explained to me what heroin withdrawal was at 10 or 12, or what heroin was, instead of making it so demonized and bad, I can honestly tell you I would have never have put a syringe in my arm. I think we need to be honest is the best word. We need to, like Liz was saying, I remember going through the DARE program and, being taught about this, the stealthy junkie in the alleyway, that was going to try to lure me in, and yeah, just say no. And to be honest, I had family members that smoked marijuana, so I thought marijuana was bad and I didn't want to be around it. So, heroin was my first drug. I was afraid of alcohol. I think back to what we were taught as kids, and coming from this Irish Catholic background, it's ridiculous. So I think that's where that if you heard anger coming out of me or kind of dismissiveness, what I was trying to say is we need, like everyone's saying, we need a whole new approach. We have to rework this. Yeah. And no, and what I was saying is I was choking up there is I'm working with 16-year-olds who are overdosing in porta potties at skate parks. And how do we address that? I'm not a mandated reporter. I can't go to their parents. So there's a lot. We're at this epitome of kids, young kids that are dying. And how do we change that?
I would just like to add something here because the governor just passed some legislation that includes a whole section about prevention. And I was just reading it, and it includes education in schools and expert in schools and of some innovative ideas. So I know that it is on the mind of the governor and the team that's working with them. The Attorney General, I know, is very interested in prevention in schools. So it is on the radar, and we don't know exactly what they have in mind, but they are talking about funding for schools and prevention.
Great, thank you.
Hi, I'm Tim Allen. I'm on the Springfield City Council, and there's been a few things said tonight about government's involvement and needle exchange in Springfield. Springfield took some hits tonight in this commentary. And I don't want to be defensive about it. I just want to be like, what can we do?
It's a great town, and we're all here.
I
so.
know, I know. So I've been on the council for 8 years. I finished in my 8th year. And I don't recall this ever coming before us in a discussion format or a voting format. So while we may be behind where we should be, the best work we do on the council, because there are so many things, we'll have an agenda of 30 different things. And while we have to dive deep on some things, we can't dive deep on everything. And it works best when community works with us. And experts from the community come, pick a counselor, say, how do I get involved? How do I get the council engaged in this? Have a couple committee meetings, whatever it is. And when we work that way, we're much more effective on special initiatives. The normal stuff, we don't need to do that, the normal agenda of the council, but special things that require special attention. So Liz, I think, if that's your name, Liz, from Tapestry, maybe we should meet, et cetera, on some of the things you talked about. So,
I also, well, you weren't done yet.
I can't commit to what would happen. I learned a lot here tonight. I came here on my own just because I saw it, and I'm aware of the problem, and I just wanted to get as educated as I could on it. But I'm happy to try to be a gateway to at least discussion at the council, if not policy change.
Yeah, definitely. I will definitely get in contact with you. And the law did change about a year ago, so now the approval is sought through the local Board of Health, and the Springfield Public Health Council is currently talking about it, and I believe they're going to vote on it in January.
So I was chair of the Public Health Council before I got elected to the city council, so we're in the same world, okay? I'll give you my card.
And I do want to say, though, that I found with just my experience with Holyoke and other places, the real battle has always been after it's been voted in. Just in Greenfield in this past year, we have not been able to secure a site in this town of Greenfield until very recently. A church opened its doors for us, and then not even a week after that, there was a counselor brought up the question of if had proper zoning to be in that space. So now we're dealing with that battle. And that's how it's been, I think, in many places. So I am looking forward to talking to you more.
Okay, so.
And I'm looking forward to talking to you.
Okay. We dealt with medical marijuana. Now we have to deal with recreational marijuana. That is going to be a tough one to deal with.
It is.
And because of the lack of kind of guidance from the state so far. And we have to do something with that by next summer or extend the moratorium or whatever. That's so there's a lot of stuff kind of in this area that we've had to do, in the marijuana field. But I'll give you my card. Maybe we can get together. All right.
I think I can speak for everyone on the panel. We're happy to be at your service.
All right, great.
Thank you, Mr.
But
Allen.
I'll be at your service, but you guys got to bring some energy and some ideas to it, and I'll open the door.
You didn't get a sense of energy tonight?
I got some.
Great.
Thank you.
Is this the last question? Or no, we have one more?
Somebody else behind me.
Okay, this is not the last question.
My name's David Morse. I'm a retired PA, but I've recently been involved with advocacy around criminal justice reform. And I guess I was going to ask exactly what Tim said. Why aren't you meeting with City Council and making this happen? Springfield is behind the times. Why isn't there clean needle exchange? Why isn't the public health community working with the politicians? I work Pioneer Valley Project, Arise for Social Justice. There are people in this town who will work with you folks. You just need to mobilize us, not just the medical community, but needle exchange should happen here. My question was, the criminal justice reform has included mandatory minimums for fentanyl and stuff like that. It may not come through in the compromise, but what are your thoughts on advocacy for criminal justice reform and we got a lot done, but some stuff may be backwards.
So I think it's a critical time right now. With overdose, the public safety or law enforcement or criminal justice or corrections, all of that, all of those institutions that are actually traditionally aligned with the drug war are thinking differently in some ways, but then also at the same time falling back on old strategies that don't work. So, this coercive treatment through the Section 35 legislation is one example, but, equipping police with naloxone, not the sort of thing that makes the biggest difference as far as reducing overdoses. However, giving them a tool where they can save somebody rather than arrest them is really, it engages them in the problem in a positive way. There's this movement right now in Massachusetts across the state to do post-overdose interventions where you have essentially a knock and talk is one of the things that we call it. It's where you have a lot of times a public safety, which means police or fire or EMT, with a public health worker, which in some cases could be somebody who's enlightened in harm reduction, but in other cases could be somebody who's very strictly focused on treatment. So this is a promising possibility where you have a partnership between public health and public safety, but it's fraught with issues that could potentially undermine the benefits of it, like disclosing people, privacy concerns, or there are some knock and talk programs that actually do coercive treatment as part of what they're doing. So this is a really critical time, and I think we're going in both directions at the same time. You mentioned, trying to prosecute drug dealers as murderers, right? Is people who don't really understand how that is appealing to people who don't really know about addiction, because especially if they've lost a loved one and they want somebody to blame. It's extremely hard to do those prosecutions, and there's no evidence that they're effective. If you have a drug dealer, we have enough laws on the books to put them away for a very long time. A murder charge, it takes up tremendous resources that oftentimes aren't going to work. So it's another example. So in every one of these, there's two ways to go, and we need a lot of advocacy and information around that.
What you meant to say, it takes up a tremendous amount of resources that could be used somewhere else more effectively.
And many times.
Many times more effectively. And I agree with Alex's point. Just about your comment about talking to, part of the reason for doing this forum was to start this conversation and to start to think about how do we mobilize our community to do more about this problem. And so I'm glad you brought that up. Yes, so I'm hoping, it's funny, people ask me, what are you hoping for the outcome to be from this? I think part of it is for those linkages to be made, for people in city council and other policy-making agencies to sort of think, there is some science here, maybe we should do things differently. So that's what I'm hoping will come out of this. So this is sort of the beginning of a conversation, it's not the end.
What I was saying is, we have to also look, it frightens me when we talk about persecuting drug dealers as murderers, because many times that drug dealer could be your child. It's not, the cartel running out of the bodega. A lot of times it's somebody just supporting their habit, as we learned as the case that just happened at UMass. And as I was choking out up there, is we have drug dealers who are testing their supply who have no idea that there's fentanyl in it. So we have to be very careful, and like you were saying, it's very easy, even as myself who's lost someone to an overdose, that I want to point the finger. We have to, as a society, take a step back and look at the the problem beyond that and work for a solution.
The other issue I remember I want to say about the knock and talk, right? The knock and talk is, if you don't have effective treatment to refer, you're going to knock, you're going to offer people treatment, and if you don't have the effective treatment in place, it's difficult to think about how that intervention is going to be effective.
Hi, my name is Kimberly Pedigo. I'm a physician assistant. I'm a PA at Habit OPCO. We're an outpatient methadone provider in this city. I wanted to leave on a positive note. I wanted to thank you for your panel. But I wanted to let you know that our facility and other facilities in surrounding towns are working very hard to increase the census. We've gone from 500 to 950, and we'll be at 1,200 by the end of next year. And I know that other clinics are working the same way. I've seen a huge uptick in the number of prescribers at local facilities calling us to verify methadone doses very quickly, so patients don't have days in the hospital where they're not treated. And I've seen brave physicians at Baystate call us for patients who are not on methadone, and they have started methadone treatment in the medical facility with a direct facility-to-facility intake with no time lag in between so that they can start treatment as soon as they're discharged. I'm nervous, I'm sorry. We also work intimately with Baystate and their methadone-assisted treatment programs for the moms to make sure that the moms get care throughout their pregnancy. And we have direct admissions where a person who's identified in the facility can come right to us and be admitted immediately without a lag. And we're taking people directly from Carlson and Franklin, where they don't have to leave detox before they start methadone. They come door to door. So I think a lot of us are doing work in this area to increase access. I just got certified in the Suboxone program. But my question was for Liz. It's great to hear you speak. Thank you for your insight on the fentanyl test strips. And I'm going to push Liz to see if I can get her to be the person in the community who makes those possible for our clients to get. We started seeing fentanyl in June. Our first batch of screen had 6. Our second batch of screen had 16. And now it seems like almost all of our screens have fentanyl. It's almost impossible to find opiate in the cities surrounding Springfield that are not contaminated. So I don't know if Tapestry could play a role in making fentanyl strips available. I know you have a lot on your plate, but we have clients who come in and swear that they've taken my lab test back to their dealer, and their dealer has promised them that there's not fentanyl. And then when I tell them on the second or third test there's still fentanyl, they're just shocked. So thank you for your work. Thank you for the information. I think you're all amazing.
Thank you. I just want to say, I think a lot of people have said tonight how there are a lot of limitations around an agency and around safer injection. There haven't been any agencies that are willing to stand up in fear of federal law. And then around fentanyl testing strips, agencies haven't stepped up or been able to acquire funding because of the possibility of a false negative and the need for more research, which is why Jess Tilley and the New England Users Union and other people like that are so important in getting this going. Jess probably has more to say around this, but I do want to say Jess and some other people in the room have been doing GoFundMe campaigns to get fentanyl testing strips because there isn't any ability to get state funding or anything like that at that moment. So I just want to make it clear that Jess is doing the work out of her own pocket, and that's just how dedicated she is.
The GoFundMe site, just go online and Google fentanyl test strips, GoFundMe, and we're the second result. Or we can post the link on the event. Oh, that's a good idea as well.
And we also offer fentanyl test training, like test strip trainings. I promise I'll try not to have an asthma attack during it. It'll be very clear. I have cards that I can give out, and I don't know if that's what you were asking, but I do. Like Liz was saying, because most agencies, I'm the only person, well, New England Drug Users Union has 6 chapters, so we are doing it in each New England state, but here in Western Mass, we are the only ones giving out test strips, and like I was trying to say before, the results are phenomenal. The dialogue is priceless that's happening around them. I didn't expect it to be so family-oriented, but it is happening that way, and I'm hearing report backs from people getting their urines coming back from methadone clinics that these are individuals who have not touched an opiate in 6 years, but have been shooting cocaine or smoking crack cocaine, shooting crack, and are coming back positive for fentanyl and bringing me their lab results. So, I mean, the test strip is is what they're saying, give me a test strip, I have to test my cocaine, and it's coming back positive. So it is something I wish to God we could get into the methadone clinics and do trainings, but once again, it's not state funded. It's just Tilly funded.
I do have one more question for the doctor from Mason Square. Can you speak to the binding affinity for fentanyl? Is it a tighter binding affinity? Because anecdotally, my patients are reporting where with one Narcan with heroin, you can knock it off the receptor and people come back, but they're using multiple kits for Narcan to get the fentanyl out. And I'm wondering about how they're going to have access to enough. We're telling them to bring all that they have. If they're going to use with people, bring everything they have together, so they have a lot of Narcan available.
Want to speak to
Well, so you asked the doctors, but actually it's the folks who are taking the rescue reports, I think, who probably know even better. But my best sense out of hearing a lot of these reports is that the most critical issue is time, not dose. Naloxone far out competes fentanyl at the receptor. That being said, a fentanyl overdose looks profoundly different than a heroin overdose, and like it just progresses much more rapidly, and that a lot of responders are no matter how experienced they are in responding, are administering more naloxone more quickly because of just how shocking and how unresponsive really people are. So, you know, it's crucial, as I sort of mentioned, that and how fast these overdoses evolve. Somebody needs to be right there with the person when they're using. They have to have naloxone ready to go. And you know, I think at this point we would say multiple doses is a good idea, but I still, you know, they need to rescue breathe between doses. So you want to give time for that original dose to work, because you know the other side of this is if you blast people with too much naloxone up front, they're going to go into really terrible withdrawal, and you know then you're going to have to manage the withdrawal. So with fentanyl, we have to thread the needle in a way we didn't have to before. But I don't know if you guys want to comment on what you're hearing.
We're hearing just exactly what you said. I think you were talking about earlier how before we would say call 911, give Narcan, do rescue breathing, but it's switched these past couple years to give Narcan first because people are falling out much quicker and harder.
We would get report backs back when I was trying to say back in 2010 when I felt like our overdose rates were falling a little bit. You could tell when you got a fentanyl, or we would assume was a fentanyl report back, because our program participants were coming in and saying, well, they immediately went out like the rumor of the person overdosing with the needle in their arm. We would always tell people that doesn't really happen. But now from what I'm getting back as report backs is, it's happening immediately fast, the wooden chest syndrome. Because all of my Narcan is donated, I'm trying to keep people, also because of precipitated withdrawal, I'm trying to keep people from pushing people into withdrawal so quickly using so much Narcan. But I can say personally, responding to an overdose, I have not responded the way I have to overdose. I'm not usually scared, I'm calm during overdoses, and I've actually been scared in the last couple that I responded to because I didn't think I was going to be able to bring the person back. And that was definitely fentanyl.
But they did come back.
They all came back.
Okay, good.
Well, Jess has the last word. I just wanted to thank everyone for coming and for your participation in the question and answers. I hope, as I mentioned, I hope this is a beginning of a discussion about what we as a community can and should be doing. Now you have a sense of what the science says, and now we have to do the hard work of seeing if we can get our politics to sort of match what we know works. Well, thank you. Thank you very much.